Today I am going to discuss about the physiology of heart sounds. Before going into the topic, it is helpful to understand the anatomy of the heart. So, let us quickly brush through. As you all know that the human heart comprises of 4 chambers. The chambers are right atrium, right ventricle, left atrium, and left ventricle. Right atrium and right ventricle are divided by the tricuspid valve, while left atrium and left ventricle are divided by the mitral valve. Mitral valve has 2 leaflets, and hence the other name is bicuspid valve. The tricuspid valve on the other hand has 3 leaflets. The mitral and tricuspid valve are collectively known as the atrioventricular valves. Other than the atrioventricular valves, we have other set of valves known as semilunar valves. These valves are named so because of the fact of the shape of the valve like a half moon. The semilunar valves divide the major arteries from the ventricles. There are 2 types of semilunar valves that are the aortic valve and the pulmonic valve. The aortic valve divides the left ventricle from the aorta, while the pulmonic valve separates the right ventricle from the pulmonary artery. I have done a detailed video explaining the functional anatomy of the heart which I will link in the description below. Having said that, let us quickly understand how the heart sounds are generated. In normal circumstances, blood flows in laminar fashion. However, due to structural or hemodynamic changes, blood flows turbulent and thus it produces vibrational waves or known as heart sounds. These waves are transmitted through the chest wall and are heard via stethoscope. In other words, heart sounds are vibrating sounds of cardiac structures brought on by changes that produce turbulent flow of blood. Again, before we go into the topic, there are a few crucial things to understand about heart sounds. Those are how the heart sound is caused, different situations that can cause it, and the surface anatomy of areas of auscultations. It is also important to familiarize your ear with the sound. I will cover about the surface anatomy and heart murmurs in a separate video. Having said that, let us dive in. There are 4 heart sounds in total. Out of the 4 heart sounds, the first and second heart sounds are heard in a normal healthy individual. Most of S3 are pathologic and all S4 are pathologic. The first heart sound is also termed as S1. It is caused by closure of the mitral and tricuspid valves at the beginning of isovolumetric ventricular contraction. An isovolumetric ventricular contraction is named such because during the time between the closure of the atrioventricular valves and the opening of both the semilunar valves, the ventricular pressure rises rapidly, without a change in ventricular volume, meaning there is no ejection during that time. Ventricular volume does not change because all valves are closed during this phase. Contraction is therefore termed as isovolumic or isovolumetric. You can watch my full video regarding cardiac cycle to get better explanation regarding this. You might have read or even listened to your professors that there is split in the first heart sound because of the fact that mitral valve closes earlier than the tricuspid valve. However, let me tell you a good news. That piece of information is good to know, but otherwise, the splitting of first heart sound is neither important in the practical setting nor are you able to hear the split. So, my advice is to just forget it. It is very helpful to know about certain conditions that can increase the intensity of the first heart sound. For example, the most important factor affecting the intensity of the first heart sound is the velocity of atrioventricular valve closure. At a fast heart rate, S1 is louder than normal. The second factor is integrity of the AV valve. A diseased valve may not close completely, resulting in decreased in intensity of S1. The third factor is the mobility of AV valve. For example, if the mitral valve is calcified and fixed, S1's intensity is decreased. The fourth factor is about the status of ventricular contraction. Let us say in patients with severe anemia, anxiety or pregnancy, the S1 is louder than normal because of the stronger ventricular contraction. On the other hand, in patients with acute myocardial infarction, myxedema or cardiac myopathy, S1 intensity decreases. The last factor is the transmission characteristics of thoracic cavity. Diseases like obesity, emphysema and pericardial effusion would decrease the intensity of all heart sounds because these conditions interfere with the transmission of heart sounds from the heart to the stethoscope. Now, let us understand the second heart sound. The second heart sound is caused by the closure of aortic and pulmonic valves during diastole. Similar to S1, the second heart sound intensity are affected by the transmission characteristics of thoracic cavity and the pressure in the aorta or the pulmonary artery. For instance, in disease like pulmonary hypertension, S2 is found to be louder in intensity. You need to remember that unlike the first heart sound, the split in the second heart sound is discernible because of the pressures in the aorta are higher than those in the pulmonary artery. This means the aortic valve closes earlier than the pulmonic valve and thus the loudest component of S2. Contrary to the S1, the aortic and pulmonic valves can be heard closing under normal circumstances when inspiration occurs because of the rise in venous return. The right ventricle will take longer to pump blood out as a result of the larger volume, which slightly delays the rise in pulmonic artery pressure that triggers the closing of the pulmonic valve. The pulmonic valve closing is therefore represented by the latter sound in a physiological split S2. The third heart sound or S3 coincides with the rapid filling phase of the ventricular diastole because of the rapid expansion of the ventricles. It is a soft low-pitched sound that can be heard with the stethoscope in children and some young adults. When heard in a middle-aged or older patient, S3 indicates a disease like congestive cardiac failure. The fourth heart sound or S4 consists of a few vibrations recorded during an atrial systole in a phonocardiogram. It is not heard by a stethoscope in normal individuals. When heard, it indicates a vigorously contracting atrium against a stiffened non-compliant ventricle. Some key takeaways in this video are: there are 4 heart sounds in total. Heart sounds which are heard in normal healthy person is the first and second heart sounds. Most of S3 are pathologic and all S4 are pathologic. The first heart sound is caused by closure of the mitral and tricuspid valves at the beginning of isovolumetric ventricular contraction. The factors that affect the intensity of the heart sounds are the velocity of AV valve closure, integrity of the AV valve, mobility of AV valve, status of ventricular contraction and transmission characteristics of the thoracic cavity. The second heart sound is caused by the closure of aortic and pulmonic valves during diastole. Split in the second heart sound is discernible, unlike in the first heart sound. Second heart sound intensity are affected by the transmission characteristics of thoracic cavity and the pressure in the aorta or the pulmonary artery. The third heart sound or S3 coincides with the rapid filling phase of the ventricular diastole. It is normal when heard in children and in young adults, but indicates disease when heard in older adults. The fourth heart sound or S4 is not heard by a stethoscope in normal individuals. When heard, it indicates a vigorously contracting atrium against a non-compliant ventricle. As usual, please give a thumbs up, comment and subscribe if you find this video useful, as this will motivate me into doing more videos like this. Don't forget you can request your biology or medicine topics via the Google form that is linked in the description below. Thank you and see you all in the next video.